you all so much. It was a beautiful introduction, and thanks for having me here, and for showing up early on a Saturday morning as well. Now, before we get started, I do have a really important announcement to make here.
I'm sorry, you've all just blown up. That announcement was, I need your attention, there's something important. Outside the back doors is a box with a bomb in it. And you need to leave through this door very quickly and very quietly. That's the experience a deaf person has every day of their lives. Imagine being in an airport and there's an announcement. Your plane is now departing from the other side of the terminal. Deaf person has no idea. Get on the airplane, go somewhere else. So what I want to talk about today is the experiences of people with different disabilities, but also how to communicate with them. And this is really important, and I'll tell you why in just a second. Let's see if we can get everything technically to move. And yes, my roots are in emergency medicine. 33 years ago, I became an EMT. And that was the way I worked my way through college and medical school, so I'm one of you. Our objectives today are to learn to utilize culturally acceptable disability terminology, to implement at least 4 skills to improve communication and rapport with people with disabilities, and to identify barriers to accessing medical care by individuals with disabilities. How many of you are out in the field, working in the field? Is anyone here hospital-based? At least part of the time? A couple people, okay, good. So we'll touch on that. Why is this important? Well, in the 2002 census, it was identified that 20% of Americans have at least one disability. Some of those may be temporary and some of those may be permanent. And even more importantly, almost 8% of children under the age of 15 have at least one identifiable disability. You're going to see a skewed population because people with disabilities are greater users of healthcare services and resources. But you're also going to encounter people in your daily lives. So even if you're not encountering them on a regular basis out in the field, you may be seeing them just as part of your normal life, or you may actually have family members that this pertains to. So hopefully you'll all take something home that'll be of value. This is a video I want you to watch, and as you're watching it, I want you to think about, what do you think this woman's quality of life might be? And what do you think her intellectual capability is? Do you think that she's suffering? Oops. See if I can get this to work. Kind of difficult to watch, sometimes difficult to meet people like this. She's clearly struggling to try to speak to us. Now think about your intuition of if you were to meet this woman and what you would have thought before, and now let's see what she has to say in her own words. And I want you to understand that this is something that she wrote herself, input into her communication device, and is now sharing with you. Oh, come on.
I tried speaking in this video, but I had too much to say. I did try over 10 minutes. So, I have to use my communication device. I noticed that some people don't consider me to be normal. If you really think about the word normal, you'll realize that Just because I don't let my disability rule my life makes me strong. Or because I post videos about my disability for everyone to see and just get nasty comments from people who don't listen to what I say. Let me put it this way. I can't go out of my house without getting stared at or run the risk of being treated improperly by other people. I do this to make my life easier by educating people. So what if I need assistance in order to do certain things? So what if I have difficulty controlling some of my movements? I have so much to be thankful for. I'm intelligent. I have a somewhat and I am able to speak. I have the ability to drive a power wheelchair on my own without the use of a ventilator or other breathing equipment. And most of all, I'm healthy. I do, however, have one problem with having a disability, and it's the way non-disabled people perceive me. Like I said before, people assume that I have the intelligence of a 2-year-old, and or that I'm miserable because I have a disability. I don't want people to think of me like that. I don't want to be viewed as weird. I want to be viewed as a person who just simply does some things differently than others. I have the same feelings and desires as any non-disabled person has. Just because my physical needs are different, definitely doesn't warrant being treated any differently. Thank you.
Pretty powerful. Couldn't have said it better myself. I guess we can close now. But I do have a couple more things to say, so I guess we'll keep going. Did that change your perception? Did that change your original belief when you saw that first video? It certainly changed mine. I think she was very eloquent in the things that she told us. And in fact, in what she told us is the same kind of feedback we get from lots of different consumers. People tell us that we as medical professionals aren't doing such a good job at communicating and recognizing the abilities of people with disabilities. They give us feedback like they talk to my caregiver or my companion instead of me. They think deaf means dumb. They think they know my abilities just by looking at me. I'm underestimated. Excuse me. They tell me what I can't do rather than focusing what I can do. Or they talk to me like I'm a child. We're not doing such a good job. I want to show you one more video. It's about 6 minutes long. Please bear with it. This is Amy Mullins. Have you ever heard of Amy Mullins? She is an internationally recognized athlete and model, and also an inspirational speaker. She was born without feet, well, without bones in her legs, and required her legs to be amputated at a very early age. So you'll see one of these pictures is her on the cover of a pretty well-known magazine showing some of her prostheses. So let's listen to what Amy has to say. How can we turn up the volume?
Jackie, go ahead. Okay, so it's good.
Hello. Thank you.
Fine again.
I'd like to share with you a discovery that I made a few months ago while writing an article for Italian Water. A few months on Sandy, never running anything, but I'd already finished editing the piece, and I realized that I had never once in my life looked up the word disabled to see what I'd find. Let me read you the entry. Disabled, active, crippled, helpless, useless, wrecked, sold, maimed, wounded, mangled, effectively did for me was reshape impossible daily occurrence into a new and promising experience for me. And I have to wonder today to what extent his vision and his declaration of me as a strong and powerful little girl shaped my own view of myself as an inherently strong, powerful, and athletic person well into the future. This is an example of how adults in positions of power can ignite the power of a child.
So what Amy is telling us is the power of words, how words can affect what our attitudes and our beliefs are, and in particular about people with disabilities. So let's make sure we get it right. Let's talk about disability terminology. All of you out there, most of you out there, would be given labels by the disabled community. We would call you ABs, able-bodied. I prefer to call you TABs, temporarily able-bodied. Because honestly, none of us ever knows what the future has in hold for us. So it's important for us to understand this now. I also sometimes call you people crabs, currently regarded as able-bodied. But the disability terminology that we use should be person-first terminology. Although we may have disabilities, we're not defined by our disabilities. We don't identify ourselves as a person as a quadriplegic. I'm a person who happens to be quadriplegic. So person with a disability is preferable to the CP kid over there, or to the epileptic gentleman in the corner. So starting off, person with disability. Believe he's got a disability? Take a look. This is Nick Vukovic, I think is how you say his last name. Gentleman born without arms and legs, inspirational speaker, PhD, bit of a golfer, not too great at it, he says. As opposed to the gentleman on the other side, a pauper sitting on the ground looking for a handout. This old term of handicapped is actually so ancient it's in biblical times. And it's a term that came from the idea that somebody with a disability had no value or no worth to society other than to sit and allow us to give them charity. And these people would have their cap in hand, waiting for a handout, and thus the term handicapped. Handicapped is a very negative, derogatory term. It talks about more the value of a person rather than the fact that they might have a disability. So please, if you take nothing else out of this discussion, get handicapped out of your vocabulary. Let's talk about some other groups. How about people who use wheelchairs? We are wheelchair users. I prefer to think of myself as wheelchair enabled. Without this wheelchair, I'm crawling on the floor. I'm floor bound. I'm not bound to my wheelchair. I'm freed by it. I am allowed to get from here to there, probably faster than many of you. So wheelchair bound, chair bound, bed bound are really negative terms and shouldn't be used. Wheelchair user is a much more positive and appropriate term. Okay, so I just said use person-first terminology, right? Well, here's the exception that makes every rule. When you've got somebody who is deaf, especially capital D, it refers to a cultural group. So people who are deaf prefer to be called deaf rather than a person with deafness. Same with hard of hearing. Again, it identifies a cultural group as opposed to a specific disability. Hearing impaired, especially by that cultural group, is considered negative. People who are especially born deaf or have grown up in the deaf community feel that they have no impairment, they just can't hear. They can do everything else that you can do. Deaf and dumb. Dumb is a very old term that refers to the inability to speak, but nowadays it means something even more negative. And deaf mute. Many people who are deaf choose not to speak, but very few are actually truly mute. Some are just not comfortable with using their voices. Does anybody know who the woman is on the left? She's a world-class percussionist. Her name is Dame Evelyn Glennie, deaf from birth. She is considered the premier solo percussionist in the world right now. She can feel the vibration of the music. Absolutely stunning. If you ever get a chance, look her up on YouTube. Okay, how about some other terms that we need to avoid using? Suffered. I hate this term. I see it in medical records all the time. This patient suffered a traumatic brain injury as a result of a motor vehicle crash. Well, that's not for you to say. Suffering is a very subjective term. We should use the term sustained, because as we heard from our first video, most people who have disabilities aren't suffering. Some may be, but that's up to them to identify. Victims. This person's a victim of cancer. This person's a victim of spinal cord injury. Negative term. Get rid of that. Let them decide. Stricken. Oh, it's like a curse. Horrible thing. Crippled. Ooh, don't like that one. Lame. Lame excuses maybe, but people aren't lame. These last two I have highlighted in kind of a yellowy orangey color because proceed with caution on those. Differently abled is a term that's been developed to try to be PC, politically correct, but some people find it really kind of condescending or patronizing. So use that one with caution. Also challenged. Ooh, she's physically challenged. That's better than saying she's handicapped. Maybe, maybe not. So be careful with the terminology that you use. But as Amy told us, when we change our language, it's not enough. It's a good start, but we have to change the attitudes that go behind that language. And here we have the Department of Dependency and Care and this woman giving labels saying, come on, one more label and you're ready to face the world. Well, we need to change that whole attitude and start looking at abilities as opposed to disabilities. Here's a quote I use. This is the medical model of disability, focuses on abnormality, impairment, and limitation, rather than function, ability, and achievement, because that's what's really important. This is a group of children playing a sport called Sledge Hockey. Has anybody ever heard of that? It's a cool sport. They play it at the Chiller. These kids can be amazing. It's a parallel sport to ice hockey, played on the ice, on these little tiny sleds with two little runners, and they use the picks in their hands both as sticks and as propulsion aids. Very cool sport. This reminds me that as a pediatric physiatrist, rehab medicine specialist, I am frequently charged with giving parents the information that their child has a disability and may or may not be able to walk. And their first question to me is always, well, will my child be able to walk? And I can tell them with complete credibility that walking is highly overrated. There is much more important things in life. There are much more important things in life than walking. And what I need to help the parents understand, and what you can also help families understand or patients understand, is what are they really asking? What they're asking us is, will my child, will my family member function, be worthy, be valued, be able to participate? It's not just will they be able to walk. It's what can they do, how will they be seen by society, and will they be included? And once you can get over that hurdle, the rest is easy. Amy had this quote later on in her talk, and it says, in our desire to protect those we care about by giving them the cold, hard truth about their medical prognosis, or indeed a prognosis on the expected quality of their life, we have to make sure that we don't put the first brick in the wall that will actually disable someone. So our perceptions have an incredible impact on their own self-perception. because as first responders, you folks may be the first person to tell a patient, you're paralyzed, your legs aren't moving, your arms aren't moving. And your perception of that better be life starts over from here rather than life is all over. That impact, if I used to think, you know, parents don't listen to me, they don't really remember everything I tell them anyway. Some of the important stuff they don't. But I'll tell you what, if I tell them one little thing about the prognosis of their child, they will repeat that back to me every time they come back for the next 10 years. I once told a family who asked me if their child should be in Special Olympics or regular athletics, that they had a choice to make. Their child could be the best of the worst or the worst of the best. And that stuck with them for 15 years. They chose this child to go into Special Olympics. She's now excelling at everything. She has actually just been accepted to a postgraduate program. So what we say, even the minor little things that we aren't even sure that they picked up on, stick. So let's make sure that our attitudes reflect a positivity about disability. Avoid assumptions. This is an empty wheelchair with a posse following it, and the caption says, "Don't worry, he won't get far on foot." We need to avoid these assumptions. A classic assumption is, someone who's deaf can't appreciate music. How could somebody who happens to be blind ever navigate through an inner city? How can somebody, if they leave their wheelchair, possibly get very far? Bad assumptions, get rid of those. Don't think that just because you understand by looking at them what they're capable of, don't assume that that's a fact. Many of my children have muscular problems that require them to use a big, heavy power wheelchair like mine, but they have times when they can get up and walk around the store or the school. And their poor parents get tortured by people in the community who say, your child can walk just fine. Why are you forcing them to use a wheelchair? Well, the reality is in 5 years, those children won't be walking at all. So watch those assumptions. Attitudinal barriers. Get rid of the no, you can't. Focus on the abilities. Okay, let's get to the meat of the matter. And this is actually Madonna in a meat, in her meat costume. Let's talk about the real meat. Let's talk about how we can communicate with people with disabilities directly. Some real hardcore down and dirty stuff. The first is talk to your patients, talk to these families, talk to your clients. Use a normal voice. Don't use a high-pitched voice or a loud voice. Even people who are deaf, if you use a really loud voice, it doesn't help them understand. It doesn't improve the clarity. But most people who are disabled don't have hearing loss as well, so there's no need to use that loud voice. A high-pitched voice is often, it feels condescending, so avoid that. I have trainees with me all the time, medical students, interns, residents, and we'll do the mother duck routine where I'll go into a room and we'll chat about the patient amongst ourselves, and everybody's using their normal professional voices. And then the student or the resident will go up to the patient and say, "So, Mrs. Brown, how are you today?" How would that feel if you were lying in that bed? That's pretty nasty. So just use your normal voice. Shake the person's hand. The image on the left is a Marine who happened to lose his arm in battle. And he is offering a prosthetic arm to shake to President Obama, who accepted it. Shake their hand. If they have a hand disability, if their hand is deformed like mine, if they have a prosthesis, even a hook, and they offer it to you, it's respectful to shake that hand. Maybe they'll offer their left hand. That's okay, shake that one too. If they can't do either one, maybe a gentle touch on the shoulder. Don't pat them on the head, but a gentle touch on the shoulder. Touch them. The power of touch is so healing and so therapeutic. And disabilities aren't contagious, by and large. Be respectful. Remember that even a person who can't communicate deserves the respect of having their private areas covered, of having a blanket over them, of not speaking negatively in front of them. You'd be surprised what people can understand, even those who can't speak. Provide choices whenever possible. This is especially important to the chronically disabled population who may have had an awful lot of stuff done to them and have not been given too many choices in what they want done. With children, with people with cognitive disabilities, if you give them a choice, it decreases anxiety tremendously. And along the same lines, demystify medicine. Now, if you're going to listen to somebody's chest and they're not an extremist, maybe you'll let the child actually touch or hold the stethoscope or let them listen too. I wouldn't suggest with an IO needle, but if there's something else that you need to do, like look with a flashlight in your eyes or your mouth, you can demonstrate on that on yourself. Probably not so much the IO needle, though. Don't be afraid of the normal idiomatic expressions. Those of us who have disabilities use these terms too, and we're very comfortable with them. People who happen to be blind say, "See you later." "Have a seat" is not an insult to me. Have you heard about? Yeah, deaf people have heard all about that. It's all the gossip. Go for a walk. That's okay. I would much rather you say, "Go have a seat in the waiting room," than "Go park it over there." Okay. Now I want to talk about specific people with specific impairment groups and talk about some specifics within that group of how to engage those people. So let's start with talking about people with mobility impairments. I want you to recognize that mobility devices are part of a person's personal space. So if someone is in a wheelchair, don't lean on their chair, don't grab the handles of their wheelchair. If they happen to be in bed beside their wheelchair, don't throw your jump bag on their wheelchair. That's not appropriate. That's part of their personal space. Try not to move things out of reach unless it's absolutely necessary. Emergency situations, all bets are off. But if it's less than an urgent situation, when at all possible, keep that mobility device nearby or move it back when you're done. Ask before assisting. Down. She's a little ahead of a queue. Good girl. Ask before assisting and wait for them to tell you how to best assist them. For example, I can transfer myself using my arms. I may ask you to help grab under my legs. People's first instincts are to grab me under my arms and legs. I took a tumble in the Garden of the Gods in Colorado Springs. I was so amazed by these massive rock structures that I was looking up as I was pushing my manual wheelchair, went into a humongous pothole, and the next thing I know, I'm doing a somersault. Got a 4.0 from the French judge. But the immediate instinct of the bus drivers who were watching this was to run over, grab me by the arms and legs, and pick me up in the air. And I had to say, wait a minute, put me down first, and let's turn my wheelchair right side up first so you got someplace to put me. Likewise, Likewise, if I'm pushing a door open, your first instinct is to run and grab that door and help me hold it open. But in all honesty, I'm quadriplegic. I don't have muscle strength in my trunk. So if I get my arm on that door and I'm using that hand to brace that door open, it's also bracing me up. And if you pull that door out from my hand, suddenly I'm tumbling forward. So ask first, how can I help you? And please, if somebody's going through a doorway, almost all doorways allow a wheelchair to go through one of the two doors. So don't prop one open and grab your arm and stick the other one open, because your deodorant may not be working really well that day. And I don't want to be the one to test it out. Even transferring from bed to chair. Again, as I said, I use my arms to help me transfer. So I'm going to ask you to grab me under my knees. I feel empowered that way. If you grab me under my arms and legs, I suddenly feel 100% dependent upon you, and that's a very frightening thing. I don't like it at all. So ask, wait for them to tell you, and follow their directions. Don't pat a wheelchair user on the head. Wheelchair users are not Sherpas. If you happen to be going out the door with that person and you're going to load them up into your wheelchair van or your ambulance, don't put your jump bag on their lap or on them. And whenever possible, get to eye level. I have the advantage, and so does the gentleman in this iBot chair, of getting to your eye level, but in most cases people can't. So it's respectful if there's going to be a long conversation to get down to that person's level. If you can kneel or if you can sit, that would be very helpful. Trust me, on a crowded elevator, the view from down there ain't so good. And if you can imagine somebody who has neck weakness like I do, or has neck pain, looking up all the time at the giants can get uncomfortable. Reducing architectural barriers is something simple. For those of you who might be hospital-based, this is pertinent. For any of you who may have a family member or friend, who happens to have a mobility impairment, this is also pertinent. So in a hospital waiting room, remove a couple of chairs. It's much more inviting for me to go someplace where they've removed a chair and I can sit against a wall than to have to sit right in the middle of the entire waiting area, especially in an emergency room. And we know the abuses of the emergency room, of everybody in there with a cold at 4 o'clock in the morning because they didn't want to have to wait to see their pediatrician in a day or two, and everybody's coughing and spewing. I don't want to be right in the middle of that. In the elevator lobbies, can you get to the buttons? Is there a big trash can sitting in front of it so it's blocking access? Are light switches blocked? Are door openers blocked? This happens to be an image of the 5th floor at Nationwide Children's Hospital. I'm so embarrassed to show this. But aside from the fact that that door opener switch is at this height, that trash can is blocking both the door opener and the telephone. Not a good situation. So move waste receptacles. In the bathroom, don't tuck it in under the sink. If somebody's in a wheelchair, they need to get under there to be able to wash their hands. Do bathroom doors open out? Another little hint for somebody with hand impairment, put a sock on your own hand. Can you open the doorknobs around your facility? If you can't, somebody with hand impairment probably can't either. And then in hospitals, are the exam tables height adjustable? Do they allow a person to be able to transfer themselves independently, or are you going to have to do all the work for them and give them that, or take away their level of independence? Okay, a subject that's near and dear to my heart. Let's talk about working with deaf and hard of hearing clients. Again, reiterating that deaf is considered a culturally appropriate term. It's not an insult, it's not person first. If you have a person who's deaf that you're dealing with, ask them what their preferred method of communication is. Don't assume that everybody who's deaf can sign. Don't assume that everybody who is deaf can read lips. I can't read lips to save my life. But even the most skilled of lip readers only understand between 30 and 50% of spoken language. So what you say to them, they're going to have to fill in an awful lot of holes. Get a deaf person's attention before you speak to them. Deaf people rely on their vision so much that if you're not looking at that person, they don't think you're paying attention to them. How do you get somebody's attention? Tap them gently on the shoulder, wave a hand in front of them. You're not trying to land a 747. You're not doing all these wild movements. You can flick the lights on and off quickly in the room. On a hollowed floor, you can stomp on the floor and they'll feel the vibrations. These are nice ways to do it. If your person identifies themselves as oral, or in other words, somebody who speaks and reads lips, you want to speak clearly and avoid shouting. Shouting distorts your oral movements and makes it much harder to understand. Don't exaggerate what you're saying. It's very, very difficult to understand. Again, maintain that eye contact. If they don't get what you said the first time, say it again the same way. They may just have missed a word or missed a syllable. If they still don't get it, then try rephrasing the same question in a slightly different way. Avoid the N word. The N word here is never mind. Never mind tells a deaf person, you know what, it takes too much of my time and effort and energy to make you understand, and it's not important enough anyway. Ooh, bad message. Pantomime, gesture, write notes, do something. Help the person to understand what it is you're trying to get across. Understand that if somebody is trying to read your lips, all of these things are going to make it much more difficult. Facial hair, especially this guy. Accents. If you've got chewing gum or food in your mouth, if you mumble, if you've got really thin lips or you don't move your mouth very much, those will all interfere with the ability of somebody to understand what you're saying. Now, if a person tells you that they do sign and they request an interpreter, we're obligated to provide interpreters on request. In the field and in an emergency situation, that's not always feasible. You may have to rely on notes, or you may have to rely on family to interpret for you. That's never acceptable in a hospital. It's almost never acceptable to rely on a family to interpret anyway, except in an emergency situation. They're too subjective. They're not professional interpreters. They're not going to maintain neutrality. They're not going to maintain a code of ethics. If you do happen to be working with an ASL interpreter, here's some hints about how to use that person. Signing is continuous, and it's simultaneous with speech. If you've ever worked with a foreign language interpreter, you know that you have to pause every sentence or two to let them catch up. With a sign language interpreter, just keep talking. They will keep up. Spell names, spell medicines, spell diagnoses. If the interpreter doesn't get it, the patient won't get it. Make sure it's clear. Use a visual aid. Point whenever you can. Drawing. Make eye contact with the deaf person. Don't look at the interpreter, look at the deaf person directly. And speak to the deaf person. The interpreter is going to say exactly what you say. So if you say, tell her I want to check her pulse, the interpreter is going to say, tell her I'm going to check her pulse. Who are they talking about? Oh, me? Speak directly to the deaf person. The interpreter is going to interpret exactly what you say in the first person. Be careful about writing notes with somebody who is culturally deaf. If someone has been born deaf, grown up signing, English is their second language. The grammar structure for sign language is totally different than the grammar of English. Sign language is not just English on the hands. So what you write may not be clearly understood, just like if you were trying to communicate with somebody from Somalia. If you wrote it down, they may still not understand you. So make sure that it's clear, keep it brief, to try to facilitate communication. Okay, let's move on to the group of people who have cognitive impairments. And in this group, we would include those with developmental disabilities, like Down syndrome. We would include people who've had strokes, traumatic brain injuries, and so forth. With these folks, we want to speak in clear and concise sentences. Keep it brief. Don't start going off on a bunch of tangents. They can't follow you. Simplify the words you use. And use concrete concepts. Not, have you been having pain for a long time, but do you have pain today, and did you have pain yesterday? Keep it concrete. Match the person's vocabulary and their rate of speech. Their rate of speech will usually give you a pretty good idea of their own processing speed. So if you talk way fast and they're talking really slow, they're probably not getting everything you're saying because you're going too fast for their brain to catch up. Confirm that they understand what you're asking them by rephrasing it. Maybe you'll say it as a positive question one time and then as a negative question again, but maintain facial neutrality. People with cognitive impairments in particular are much more interested in pleasing you than they are in making sure they understand. So make sure that they're getting it and that they're answering what you're really asking. Down. Good girl. Use pictures, drawings, models, point to their body parts whenever possible to try to help facilitate that communication. And be patient. People who have speech difficulties or who have slow processing, if you hurry them by asking them again, well, do you have pain? Well, do you? What number? Is it 0 to 10? How bad is it? Where is it? What can you describe it? All of a sudden, they're so stressed out that it becomes garbage in, garbage out. The quality of the information you're going to get back from them is not going to be worthwhile. So be patient. Again, urgent situations, all bets are off. But in less than urgent situations, these are going to be very helpful hints for facilitating communication. People with behavioral and social impairments, this may include people with autism, with Tourette's syndrome, and then a whole spectrum of pervasive developmental disorders. Try to avoid being judgmental of their behaviors, especially somebody with Tourette's. It may escalate their tics. Or a child with autism, even if the child doesn't pick up on your judgmentalism, the family will, and it'll negatively impact your interactions with them. Try to establish a rapport before you start touching. People with developmental disorders like autism find touch to be a very negative thing. It may feel like you're intruding on their space. They may become very withdrawn. They may become much more aggressive. If you do have to touch them firmly. Don't touch them lightly. Light touch, tickle, that can be very negative feeling to somebody with autism. So a firm touch is better than a light touch. Be ready to be flexible in how you examine them. If it's a child, you may ask their parents to hold them for you. You may want them to have a favorite toy or a blanket, something that will help calm them down, maybe some headphones and some music. If it's an adult, if it's safe for them to walk out to the squad, allow them to do that. If it's not, again, as little touching as possible. And lastly, set reasonable expectations. Just because a child has autism doesn't mean it's okay for them to tear apart the back of your squad and start biting you. So set those reasonable expectations. Even if the parents aren't, it's okay for you to. Sometimes we have to model, as medical professionals, what's appropriate and what's inappropriate to the families. So, summing it all up, I want you to just think about the language that you're using, how that language affects the attitudes that you bring, and how we can influence people's outcome and people's interactions with us based on those attitudes. And remember that the person that you see in this crisis situation may look like this on a better day. Somebody with bilateral amputations and running a marathon, or running a sprinting race. He actually petitioned to race against able-bodieds, and it's in front of the IOC, the International Olympic Committee, because they are stating that this gentleman has a mechanical advantage over people with legs because of the energy storage within his prostheses. Okay. Here are some references if you'd like them. I want to leave the last few minutes here so that we can answer questions if you have any. We'll give you a chance to break before your next talk. I don't bite.
If you're dealing with someone who does have a disability, the question is often that you speak to the family instead of the individual. But if that individual cannot communicate, is it more acceptable to communicate with the family or to continue to struggle with the patient?
That's a great question. Did everyone hear the question? Do I need to repeat it for the camera? No? Okay. So in response to that, what I generally do is I start off always talking to my patients. I always assume that they can understand, because I've been burned. I used to not speak to a couple of my patients who I thought couldn't understand anything, until one day I asked one young man who doesn't speak, doesn't move, he's quadriplegic, cerebral palsy. I said, do you want to start with your arms or your legs? And he picked up his arm a little bit. That was the first time I knew he could understand me. So I will always speak to the patient first, give them an opportunity to answer, and then I look to the family member for that same question to get verification. We as healthcare professionals don't do a very good job about reading our patients, about understanding what their expectations are, or understanding what their quality of life is. Parents do a little better, but they're still off. This is a really hot topic now in research. So we aren't so good at it. Parents are better, but the patient is always the best. So I'll go back and forth from the patient to the family to get their support. They may say, yeah, absolutely, or they may say, no, that's not quite right. But I always try to engage that patient regardless of what I think their ability is. Avoid assumptions. Great question. Anything else?
I work in Lancaster for a center for adults with disabilities, and we just have received an individual in our program in the last 2 weeks that has PKU. He's on several different medications, and he acts out behaviorally and has been kind of violent towards staff. Do you have any suggestions that we could use to calm this individual? I know, being new surroundings, everything, it's got to be hard for him. And I just wondered if you have any suggestions that may help us.
I'm curious how old this person is.
I think he's 23.
Okay, so he's recently out of school. In school, he would have had an IEP, an individual education plan. As part of that IEP, he would have had an MFE, a multifactorial assessment, which includes a psychological examination. The schools will always include, for patients like this, for people like this, a behavioral component. I would start by talking with the family and asking them, what do you do behaviorally at home? And could you provide me with the suggestions that the school has used previously for dealing with these behaviors in their educational environment? And that's probably going to be the most useful thing for you. But working with them together to get that information rather than starting from scratch.
Our behavioral person that is on staff, when he is acting out, we are to take his hands if he is hitting people and just, hold his hands for maybe 15 seconds, try to talk to him calmly, ask him if he wants to take a walk or go do something else, that he would like. But it hasn't seemed to work very well yet.
I would go back to the family and to the IEP and look at what's worked before. In many instances, when people become agitated because of cognitive disabilities, holding them down ends up escalating behaviors. Wrist restraints can really escalate behaviors. So sometimes just removing them from the very stimulating environment may be sufficient, allowing them to burn some energy. For some people, the use of headphones and gentle music may be sufficient to help reduce some of that anxiety or that aggressiveness. But sometimes holding the hands down will work against you. In the corner, yes.
You mentioned that individuals with autism frequently don't want to be touched. How do we go about assessing vitals?
Start off by talking with them. Engage the family if there's family present to help you. Keep the touches firm but gentle. And just minimize it as best you can. Sometimes even we in the hospital can't get an accurate set of vitals because the instant that blood pressure cuff goes on, they're screaming, flailing, fighting, and the blood pressure is going to be artificially abnormally high. So sometimes you just got to do the best you can. I guess it depends on the situation. I mean, you're always going to use capillary refill, color, breathing, respiratory rate, appearance of distress. I mean, those are the things that you do as much as you can by looking at them first without actually touching them. This works for all children, by the way. I do 90% of my assessment before I actually touch a child. And utilizing, again, if they've got a favorite toy or a blanket or something to help calm them down, that can be very helpful. If there's a family member that can distract them or cuddle them or hold them, that may be very useful. Sometimes you just fly them by the seat of your pants. Was there another question beside you?
Going back to what she said about individuals in group home settings or daycares, I work for a private ambulance, and we would get called in frequently for quote-unquote combative people, and they try to take a swing at our heads and stuff to the point where, for their safety and ours, we would have to restrain them to some extent. Are there better ways of doing it than the poor people take one arm, one leg, and...
No, your safety is number one, followed by the patient safety. Absolutely. I go into self-preservation mode for those kids too. Yeah. If there's no good way to de-escalate them, and with children, you can swaddle them. And that will help quite a bit because that's very comforting. But for an adult, and some of these adults with autism can be incredibly powerful. Yeah, you got to tie them down. Yeah. Your safety, if you can't stay safe, then you can't help anybody else. Yeah. That's why I said all bets are off in an emergency situation. All bets are off. Other questions? Thank you so much for inviting me. It's been a pleasure speaking with you all. Well, I'd love to participate in the rest of the afternoon, the rest of the day's events. And Kitty, I'm really sorry because I wanted to hear your talk very badly. I have a funeral to go to, so my apologies. If anybody has questions, send them to Sherry, and I'll be happy to respond by email.